Welcome to our presentation. Then, we're going to discuss paroxysmal nocturnal hemoglobinuria. Our speaker is Dr. Mmathapelo Ntseke-Maseko. She is a consultant hematologist with over 5 years of experience in both benign and malignant hematology, as well as laboratory quality control management. She holds a medical degree from the University of the Witwatersrand and completed her specialist training in hematology through the National Health Laboratory Service and Sefako Makgatho Health Sciences University. In addition to her diagnostic responsibilities, reviewing peripheral blood and bone marrow morphology, coagulation studies, immunohaematology, etc., Dr. Ntseke-Maseko is actively involved in the training and mentorship of laboratory technicians and technologists in hematology. She is passionate about delivering compassionate, patient-centered care and works collaboratively with multidisciplinary teams to ensure accurate diagnoses and tailored treatment strategies. Thank you so much for coming. We appreciate it.
So much. Okay. So
you can begin.
Okay. Hi, everybody. My name is Mmathapelo, and the topic for today is on PNH 2026, paroxysmal nocturnal hemoglobinuria. Now, these are our objectives for today. So I will start off with defining the topic PNH, and to highlight the fact that although it is a rare condition, it is associated with serious consequences, and then it is delayed. The diagnosis is delayed mostly because the patient presents with non-specific symptoms. Then we will talk about the pathophysiology with a special emphasis on the complement cascade and how it should be regulated. Then proceed to talk about the clinical spectrum and highlight the catch criteria, the testing methodology, as well as the treatment. And then at the very last end, we will touch base on the special clinical scenarios that are associated with complement. So now what is PNH? So now what is PNH, the core definition? PNH is an acquired clonal disorder of the hematopoietic stem cells that arises from a somatic mutation in the PIK gene that is situated on the X chromosome. Now, this mutation will then result in the deficiency of the GPI and K proteins, which will then subsequently lead to a partial or total absence of the CD55 and CD59. Now, what are the CD55 and CD59 proteins? So these are the complement regulatory proteins that are there to protect the host cells against complement-mediated destructions. Now, following the loss of these complement regulator proteins, the red cells in particular will become vulnerable and will not be protected and will then subsequently be destroyed within the blood vessels. So PNH is not the only condition that is associated with loss of the complement regulator proteins. We have other isolated deficiencies of CD55 and CD59 that will lead to a distinct and separate condition that require independent diagnostic consideration. And of importance to note is that PNH in itself is not a malignant neoplasm, but then it can evolve into a clonal malignancy like acute myeloid leukemia. The presentation of PNH is usually a terrible triad. So patients will present with intravascular hemolysis, thrombophilia, and cytopenias related to a decreased bone marrow production. Now, these three features, they can either occur in isolation or in combination, and the clinical phenotype of PNH is dependent on the clone size, the cell type distribution, and the degree of complement activity. Now, the intravascular hemolysis, the complement-mediated destruction of the red cells, which will then lead to anemia and anemia-associated symptoms, whereby the hallmark is the hemoglobinuria that you will see. The patients with PNH, they are at increased risk of having thrombosis, particularly at the unusual sites and not your typical DVT and PE. Thrombosis is also said to be the leading cause of mortality in PNH. And other presentations that PNH patients present with is the cytopenias related to the bone marrow production failures, either PNH can also occur can also coexist with other underlying bone marrow failure syndrome. Now, historically, PNH used to be divided into three groups, and this was based on the presence and the severity of the hemolysis. The classical PNH, the classical subtype, is characterized by like an overt intravascular hemolysis. The subclinical PNH are those patients that are generally asymptomatic despite having a small PNH clone, and then the PNH that occurs in the setting of other bone marrow failure syndrome. Now, this distinction is particularly important because the aplastic patients, 50% of them are said to have some sort of like a PNH clone, but then not all of them will be hemolyzing. So the aplastic anemia in the absence of hemolysis should be treated as an aplastic anemia and not PNH. Now, they have proposed a new classification where they are dividing the PNH into purely hemolytic or hemolytic in conjunction with cytopenias due to insufficient red cell production, or those with irrelevant clones. And then just recently, they are looking into thrombosis as a special category as well, because I have mentioned that thrombosis is one of the leading cause of mortality in PNH. So they are then subclassifying them into either a hemolytic process or hemolytic plus thrombosis, or a thrombotic process. Now let's look at the complement pathway, because I mean it is the pathophysiology of PNH. So the complement system is the body's ancient defense system that is evolved to protect the host against pathogens, particularly against the encapsulated bacteria. It is made up of over 50 different proteins that are constantly on patrol, ready to interact, cleave, and combine to complement antibodies. So we have three different pathways based on the order of discovery. We've got the classical pathway and the lectin pathway, as well as the alternative pathway, which all share the same goal, and that is of pathogen eradication. Now, the classical pathway is initiated and activated by the antibodies, the IgG and IgM, whereas the lectin pathway is activated by the serum proteins like the mannose-binding lactins and the ficolins, and the alternative pathway, which is the pathway that is mostly particularly important in PNH, it is always activated, but then however at low levels, and this is because of the continuous hydrolysis of C3. Now, all these pathways, they converge into a C3, which is the central amplification node of complement system, and then therefore they will then activate the downstream complement proteins that will ultimately lead to the formation of MEC, and then the cell will be lysed. Now, because complement is a normal mechanism, it should be regulated, because otherwise the host cells will start to destruct. The normal cells will just be destructive. So we've got regulatory mechanisms to ensure that the complement has to stop in the absence of any pathogens or any triggers. Otherwise, it will just continue uncontrolled. And we've got like the 3 stages of complement regulation, including stage 1, stage 2, and stage 3. So stage 1 is whereby the C1 inhibitor stops the initiation and the activation of complement. And then the stage 2 is when the complement antibodies, together with the cofactors, they break down the already formed complement complexes. And then this stage, the CD55 is particularly important in regulating the space of the disease, of the regulation of complement. And then stage 3 is basically the prevention of MEC formation. And the marker that is important is CD59, which physically blocks the polymerization of C9 and ultimately blocking the MEC formation. And then you also find some proteins in the serum that will mop up any loose findings, MEC building pieces in the blood. Now, in PNH in particular, it is the loss of the CD55 and the CD59 against the red cells that will then make the red cells to be like vulnerable. In PNH, we also talk about phenotypic mosaicism, and this is based on the expression of the GPI anchor proteins. Now, the type 3 cells are said to be completely deficient of the anchor proteins, and then 10 to 15 times more sensitive to complement attack. The type 1 cells, on the other hand, they have normal expression of the GPI anchor proteins, and then these ones are said to be derived from a non-mutant hematopoietic stem cells. The type 2 cells, they have partial deficiency of GPI anchor proteins because of the residual activity of the PK gene. So most patients will present with the type 1 or the type 3 cells, and then it is the proportion of the type 3 cells that will result in the severity of the hemolysis. Now, I've already spoken about the symptomatology that PNH presents as a terrible triad. I just wanted to highlight that once you are faced with such a patient, the basic investigation will be a full hemolytic screen, particularly the direct coombs, because in other intravascular type of hemolytic anemias, the direct coombs in PNH is usually negative, so it serves as a distinction from other intravascular hemolytic anemias. So these are the additional tests that one will do. The iron studies, because the patient will be having like a chronic blood loss and subsequently becoming iron deficient. So you can also do iron studies, also folate assays because of the chronic hemolysis. Bone marrow, it goes without saying, because this will help to classify either PNH in isolation or occurring in a context of other bone marrow failure syndromes, and then we proceed to do the ancillary tests. And we should all be aware of the differential diagnosis. These are mostly the other type of conditions that are particularly have intravascular hemolysis. So, like I have said, that the direct coombs is negative as a distinction to those differential diagnoses. Now, this slide is just to highlight the difference between the intravascular hemolysis and the extravascular hemolysis, to say that with intravascular hemolysis, the anemia is usually acute and severe and is characterized by hemoglobinuria, whereas the extravascular hemolysis, the anemia is usually milder form of like hemolysis. Now, this is the CATCH criteria that was developed by the Canadian network. This is just to help them to early identify the patients with PNH, so that you can test them timeously. Now, the gold standard for testing the patients with PNH is by flow cytometry, which is highly sensitive and highly specific. So it will identify the absence of the GPI and CATCH proteins on more than 2 cell lineages, the granulocytes and the red cells, and also enumerate the PNH clone. So now the granulocytes, it provides the most reliable clone size measurements because it's not subjected to intravascular hemolysis like the red blood cells. So this picture here, it shows that on a normal patient who has adequate CD55 and CD59, you can see that the red cells are positive for the CD59 and CD55, and similarly, the granulocytes are also positive. So on this diagram, anything that is to the left of the 10 to the power 1 is said to be negative. So when you look at a patient with a suspected PNH or is a PNH, you can appreciate that there are cells that are on the left of the 10 to the power 9, and these are the red cells, which are then said to be negative for the CD55 and CD59. And similarly, the granulocytes, you can appreciate the population here that is negative for the GPI anchor proteins. And then what flow will do is to measure the size of this clone. But then it's also nice to appreciate that even in the presence of a PNH clone, one would still have the normal cells. And then the other technique that is used is FLAIR in flow cytometry is a FLAIR technique, which is independent of any specific protein expression, and it directly binds or to the GPI deficient cells. So this is the gold standard of diagnosing PNH, and it is done on a peripheral blood. Now, once the PNH has been diagnosed, it will definitely need to be treated. And then the treatment is not like a one-size-fits-all phenomenon. It is dependent on the disease severity, the clone size, and the presence of complication. So a multidisciplinary approach is very essential. So we talk about supportive therapy, whereby one will need to transfuse those patients who present with symptomatic anemia, and also for those ones that have maybe thrombocytopenia, you can still like transfuse platelets in patients with PNH, because platelets transfusion is not contraindicated in the management of PNH. And because the patients are at risk of increased thrombosis, so the anticoagulation is recommended, of which the low molecular weight anticoagulant, the low molecular weight heparin, and warfarin are the drugs of choice. So we do not have any sufficient data to talk about the role of DOACs in management of PNH. The drugs of choice in managing PNH is the complement inhibition therapy. And then here we talk about the eculizumab as well as the ravulizumab. And then I will just touch base or explain like in detail on the coming slides on the mode of action of the complement inhibition therapy. And obviously like vaccination as well as infection precautions, it goes without saying that it is mandatory, because meningococcal infection is a big risk. So these patients, if you were to start them on a complement inhibition therapy, you need to vaccinate them at least 2 weeks before commencing on complement therapy. And then the stem cell transplantation will be for those patients who have like an underlying bone marrow failure syndrome. Now, this slide is just to highlight the mode of action of the complement inhibitors, the eculizumab, which is the original complement inhibitor, is a benchmark drug, the drug of choice that is being administered IV every 2 weeks. It dramatically reduces hemolysis doses and also transfusion requirements. And ravulizumab, which has a similar mode of action with the eculizumab, the difference is that the ravulizumab is said to be long-acting, but then the two drugs, they both inhibit or they block the C5 convertases and ultimately block the formation of the MAC. So for patients that are said to be refractory to eculizumab, or they do not adequately respond when they are placed on eculizumab, then they will be given ravulizumab. Then we've got other newer drugs with different mechanisms of action that are also like administered differently in relation to an IV infusion. The anti-C3 inhibitor is said to be given subcut, whereas the oral forms of complement inhibitors also do exist. Now, in terms of monitoring the treatment response, you can monitor it over a 3 to 6 months period, whereby you will be assessing 4 different parameters. And those include the red cell blood transfusion, the need for the patient to be transfused, as well as the level, the HB level, and the LDH level, and the response of the reticulocyte count response. Now, this response is based on 6 categories. The complete response measured with partial, minor, and no response. So the complete response basically means that the patient is healed and they are not transfusion dependent, they are not immunizing, whereas with no response, then it would mean that the patient is still symptomatic. And then here, you might want to change the drug that one has been using to accommodate the patients. There are other imaging therapies that are associated with PNH. We've got the novel complement inhibitors, most of them are still in the late phase trials. And then they also talk about the gene therapy and precision medicine. And then I did also mention that PNH can present with some challenges. So patients, they can present with hemolysis despite being on therapy, especially eculizumab. And then this hemolysis can be clinically significant and requires evaluation. And it's said to be due to a subtherapeutic drug level. So if we are under giving or under dosing patients with PNH, they would be susceptible to getting breakthrough hemolysis. The precipitants of breakthrough hemolysis include infection, surgery, stress, and pregnancy. And then pregnancy also is another challenge in PNH because pregnancy in itself is a hypercoagulable state. So the patients are already at risk of having thrombosis, and the pregnant ladies are also at risk of having hemolysis. And then there are also other causes of hemolysis in pregnant women. So PNH is often not investigated in this category. And then when it's there, it can result in maternal mortality and therefore, like a close multidisciplinary team monitoring is essential in dealing with pregnancy or PNH in pregnant individuals. Of note, of importance to note is that complement inhibitors can still be used in patients with pregnancy because they do not cross the placenta, so they can be administered at any gestational period. So now the take-home message for this presentation is that one needs to suspect PNH when the patient presents with unexplained hemolysis, unusual thrombosis, or cytopenias, or either those conditions in isolation or in combination. And then you will start off with doing like a full hemolytic screen, including a direct course, which is important in as part of like investigating for PNH. And then we will do the gold standard investigation, which is flow cytometry, and then classify the PNH into different types, and then eventually treat the patient. And then it's important to notice that we should also monitor the functions, because with chronic hemolysis, the patient would usually develop some iron deposition on the renal tubule, so they can go into renal failure. So it is also important to check the renal function of the patient. And I think this is it from me.
Thank you so much. That was quite a good presentation. Sorry that I come late. I had some issues with organizing. But PNH has always been one of the very interesting diagnoses that when I did my MMed, I was always forever, it's pretty beautiful, lovely. The diagnosis was to be interesting. And I've been looking for one since that time. Up to now, I haven't found one.
Diagnosed 2 PNH cases in my career. I don't know about you. It's rare that we do investigate for it the next day.
I think, if you do get cases with the elderly population will present with cytopenias.
Yeah.
So sometimes if you do, because there's a lot of patients that get bone marrow, and then you can do PNH flow, and sometimes you'll pick up a small clone. So you can look for that, you can contribute to the thrombosis in an older patient.
And statistically, how many of them do we have around in this in South Africa? What is statistic? Because you know what, we actually don't know how frequent is it actually.
So there was an article that I read, it was published by one of the registrars at TND 20, whereby there was one pregnant patient who presented with PNH. I think this was like pre-COVID. So the stats here in South Africa, they are quite minimal. Maybe it's because they are being underreported, but I think it would be like a nice, study to look at, the national statistics of PNH.
And one of the things that you highlight quite very well, that I actually probably just tell us why it's so exciting. In the past, I think when I did my MA, that was in 2009, until 2011, 2007 up to 2011. We obviously didn't have therapies for PNH. The complements biological has not come out. But now it looks like actually this progress in terms of the complements treatment. This is quite very interesting, something that we should actually be. I don't know whether that already exists in South Africa or not.
Yeah.
Because cannot be used for other conditions.
Yeah. I was informed because I was also not sure if we have the use South Africa. And I was informed that they do, like South African can access that drug. This PNH.
But also, I mean, it cannot be for PNH only. I think as a medical professional, I always say that we are like a seasonal.
Yeah.
So once you diagnose something, then you tend to go more into it and then find something more
That
complementary.
you can, it's
So- But the end's getting cold means the presentation is good. Thank you so much. Thanks for coming presentation. Yeah. And I'm looking for my first case presentation. I will always go back to the podcast again. Not that this I could not keep chasing for it until that's really one.
We'll share on that.
Yes.
Okay.
Thank you.
Hello. Anybody online? Dr. Kohli?
Yeah, good morning, everyone. A great presentation. No questions from my side.
Have you diagnosed one PNH or not at all?
No, not at all.
So you're looking like me. Thank you, Dr. Kohli. Thank you for joining us always, man. Are you getting all your CPD points?
Yes, I'm getting them, periodically,
And then please, you need to give Michelle a topic so that you can present. You cannot be a listener all the time, because it's a good platform for you to kind of, for your voice to be heard, for your patient also to see that you're doing a lot of academic work because it's shared through the Facebook and all the other media. So you can present anything that you feel great about it in Secunda, that you think that we can't learn from it. Do you think you can, I'll send you with Dr. Michelle Human number and then communicate with her to give you a date, okay?
Okay, we'll plan towards that. Thank you.